if you see the size of lesion, mean size of lesion is somewhere around 1 to 1.5 centimeter square. If it increases more than 2, then we go ahead with the 1 or 2 plugs of various sizes.
So amongst the faculty, Reha, Amit, Vivek, amongst the faculty, what is your percentage of simultaneous ACL with cartilage repair? Reha and Amit, both?
I think we have a spectrum of cartilage lesions. One is the acute scenario where you have a traumatic lesion. And the other end of the spectrum is the patients with chronic ACL deficiency and who have a chronic type degenerative lesion. So for traumatic types, I think I would go for more mosaicplasty, even in smaller lesions, because our patients with who with their microfracture have come back to us at 5 years saying that they still have symptoms. And if you look at the second look arthroscopies of these patients, the cartilage quality is very bad, even though in MRI they look good. So I think for the traumatic lesions, even if they were smaller, I would still do a mosaicplasty, because we know that earlier return to sports and better cartilage is for mosaic. How often? It's difficult to say, but let's say about 10 to 15% of the patients, acute ones, require some form of cartilage repair.
Yeah, Roshan, the exact incidence of meniscal lesion is about 30 to 37%, but majority are diffuse type rather than a focal and the localized lesion. So localized lesions are very not very common, and then if they are small, for some reason a sensitivity of MRI to diagnose these focal and small lesion is very, very low. So most of the time I go inside and then I get surprised that, oh my God, there is a focal lesion of the cartilage. So as learned from our own mistake, I always keep mosaicoplasty OAT set with me when I am planning for an ACL reconstruction. And about 9 to 10% time, OATS is the basic my mode of treatment. Because in Nepal, we don't have ACI and BMAC, we are not using it. So OATS is the main workhorse at this moment.
Okay, Dr. Narvekar, you have any question?
Not question, maybe I would certainly agree with Dr. Reha that if in case there is, the patient was asymptomatic in terms of his cartilage lesion preoperatively, then I would not touch the lesion. Just because he's now, I have got an attempt, I'm doing the ACL and I incidentally find that lesion. But if in case it is a post-traumatic, and if it is a small lesion where I can just put in maybe 2 pegs 4.5 or 1 port 4.5 and 1 6.5, then I would go ahead and do it. But I have never done a microfracture for these because I don't find it is necessary to do microfractures for these because there is enough of superclot coming from your ACL tunnels, etc. And you do not want to jeopardize any part of the subchondral bone at that point of time. And I have not regretted. So the only time that I go ahead and do something to the subchondral bone is when I have to do a mosaic for post-acute acute lesions.
Anybody has a question? Sanjay, on this ACL with microfracture, ACL with cartilage repair?
No, I think whatever Vivek has said, that it is mostly on table finding, and that is my experience. And more often than not, I have ended up doing just a microfracture. But when there is MRI confirming in chronic cases, I was able to do OATS. Otherwise, most of the time, just a microfracture.
Okay. Any comment from anyone before we jump on to the next talk? Yes.
Roshan, a small comment.
Yes.
Vivek, with my experience, microfracture versus just debridement in 40 years below patients and 40 years plus patients. What I observed is microfracture giving a bad results 40 plus or 35, 40 plus. And just debride and leave it. So these patients are doing better than doing a microfracture. Microfracture having a better results in a younger age groups. maybe because of the fibrous cartilage formation and other things. But I have bad experience towards the 50 years.
No, I can understand, because that's what we said. I think it's still a long way to go before we understand this whole mystery, you know, of the cartilage. Who will do well, what we should do, and especially these Scandinavian studies can thoroughly confuse you.
Okay, I think we should move on to the next talk.
I think we should move on to the next talk. Thanks, Vivek. That was a very nice talk.
I need to go now. Roshan, thank you.
Yes, thank you, Vivek. Bye.
May I request Dr. Reha to speak on ACL reconstruction with high tibial osteotomy? Dr. Reha, if you can share your screen and unmute yourself, please.
Moment, sharing the screen.
Yes, please.
Yeah, Dr. Reha, I'll mute everyone.
Okay, can you hear me? Yes, okay, that's good. My first talk is on combined ACL reconstruction and high tibial osteotomy. Just for those who do not know me, I am an orthopedic surgeon working in private practice in a center of excellence for arthroscopic surgery and joint reconstruction. I'm also the vice president of the European Knee Associate section of the ESCA, and also I am the associate editor of the ESCA journal. So these are my disclosures. Some of them have something to do with the presentation's content. I'll start with, do we need an HTO in patients with an acute ACL injury and varus malalignment? There's a very nice study by Kim and Associates on this topic. And even in patients who have a mechanical axis deviation of more than 15 millimeters, if this was an acute case and the menisci were intact, the results were as good as primary ACLs. So the answer for acute cases is no. We do not need to correct every varus knee we see if the patient has an acute ACL injury. However, for chronic ACL insufficiency, things change a little bit. We know that we have a physiological varus alignment, and in time, the lateral structures elongate along with the medial cartilage loss, and then we end up with a progressive varus and lateral laxity. Frank Noyce has described this almost 20 years earlier, but I think this is a perfect classification to go on because it defines our treatment strategy. So a primary varus is the constitutional tibiofemoral varus alignment plus medial meniscal tear or loss plus posterior medial cartilage damage. So this is the first stage. If this is not treated, it may go on to a double varus, which means a progressive medial joint narrowing with varus alignment. But now the lateral structures have begun to elongate, and now we have an LCL laxity more than 5 millimeters on stress X-rays, and we have a varus thrust with lateral condylar liftoff. The final stage is the triple varus. When you have all these, but you also have increased external rotation and hyperextension, resulting in a varus recurvatum deformity. So this is the last stage of the varus accompanying chronic ACL tears. So how to decide in these cases? Well, the symptomatology makes it important because if it's pain and instability, then you might do a simultaneous or staged ACL reconstruction plus an HTO. If the pain is prominent, but there is no instability symptomatology, then you can do an HTO only and then play with the tibial slope to decrease the tibial slope and then help with the ACL instability. But of course, like in every other procedure that we do a joint preservation, we should also add a cartilage regeneration or a meniscal implant, transplant, whatever, to restore the meniscal status in these chronic cases. So how should we proceed? In primary and double varus, we can do a simultaneous ACL reconstruction and an HTO. and lateral surgery is usually unnecessary. However, if we have a triple varus knee, then we should stage our surgery with first doing an HTO, and then the second part of the surgery should be an ACL plus lateral or post-lateral reconstruction at 6 months during implant removal. So how do we decide for lateral surgery? This is a difficult question. If we have the external rotation recurvatum test positive and dial test positive, if we have more than 10 millimeters lateral opening in stress X-rays, or as you can see here in this patient, if we have more than 12 millimeter lateral opening at 30 degrees of knee flexion during arthroscopy, this requires a staged surgery. So you do the HTO first, and then do the ACL and lateral side 6 months later. Should we do it on 1 or 2 stage? Well, both has its advantages and drawbacks. Simultaneous ACL reconstruction and HTO is shorter rehab, single surgery. However, it's technically challenging and might have increased complications. Staged HTO and ACL might be an easier surgery, but it's 2 surgeries and takes longer to rehab. The pre-op planning is same for all our HTOs. We all have our these kind of programs in our PAC systems where you can decide on the amount of correction. However, we need stress X-rays for these patients because we know that the varus that we see is the sum of tibiofemoral varus plus increased lateral laxity that we see here. So if we plan solely on X-rays, we might do an overcorrection. So we should decrease our correction by 1 degree for every 1 millimeter of abnormal lateral opening that we see. We prefer to do a biplane osteotomy, which is mini-invasive, medial open wedge. It preserves the bone stock. And up to corrections to 15 millimeters, we still leave the tibial tubercle on the distal fragment. However, if we plan to do a correction of more than 15 millimeters, then we reverse the osteotomy and keep the tibial tubercle on the proximal fragment to prevent patella infera. So why biplanar? If we take a look at the classic osteotomy, here we can see the line of the osteotomy that we will do. However, if we do a biplanar osteotomy, we have this area that we can use to make our tibial tunnel in that area. So biplanar osteotomy is much easier and preserves bone stock and also gives us a place to fix our ACL graft. So the situation is something like this. You do the osteotomy, you have your already have your tunnels made on the femoral side, and then the final thing is you do the tibial tunnel and fix it. The only thing that you should be aware is that this you might have to leave this screw hole empty, which does not compromise your fixation. Other than that, the surgery is not so different from a primary ACL or primary osteotomy surgery. So how about fixation? Locking plates provide rigid fixation and allow early weight bearing. Some surgeons allow immediate weight bearing if they do a locking plate and the lateral cortex is intact. The spacer plates, I think, have more complications, especially if the lateral cortex, as you see here, has fractured. I think they lose all their stability if the lateral cortex is fractured, and they are more prone to collection loss in these patients. So even if you have a lateral hinge fracture on the open wedge osteotomy, if you have a locking plate, as you can see here, you can just add this cortical screw, the compressed lateral side, and your fixation will not be compromised since this lateral cortical screw compresses this lateral hinge fracture. How about the tibial slope in primary ACL injury? Well, we know that the increased tibial slope results in high force. Yes?
Riah, just a minute. I'll mute someone. I think he's making a lot of noise.
Yes, please. Okay, I think I'll go on. We know that increased tibial slope results in high forces on the ACL and increases anterior translation. And this is also a risk factor for acute injury. And the increased slope may be a result in a higher rate of lateral meniscus tears during the ACL injury in primary injuries. How about in failures? We know that an increased slope is also a risk factor for failure after primary ACL reconstruction, and anterior closed wedge osteotomies should be considered in revision cases, not in acute cases, to decrease the tibial slope. There are several types. They can be of a supratubercular osteotomy or infratubercular osteotomy, depending on your technique. The thing is to decrease your slope. And if you have a patient who has had multiple surgeries and the slope is greater than 12 degrees, it is very important to do a slope reducing osteotomy in these cases to prevent failure. However, we know that primary osteotomy is not currently indicated in acute ACL reconstruction. We should also be mindful of our slope during HTO and ACL reconstruction, because on your left side, you can see that this osteotomy has resulted in increased slope, which is very bad for the ACL graft. And we know that if the slope is greater than 12 degrees, we have a 3 times risk of graft failure in combined osteotomies. So what we should do is you should see something like this, a trapezoidal opening of the osteotomy site with more opening on the posterior part and less opening on the anterior part, and not increasing the slope if you are doing an HTO combined with an ACL reconstruction. So what are the principles that we use? We almost always use a hamstring tendon graft, and the same incision can be used for open wedge HTO, thus preserving the tibial tubercle. Allografts or the contralateral hamstrings can be used in revision surgery. And we always do a single bundle ACL in these patients because we don't want to play around with double bundles and double tunnels in these patients. So the surgical steps are harvesting and preparation of the graft, meniscal and chondral surgery, femoral tunnel first, then the osteotomy. I use a bone graft in all cases. Even most people believe that if you're doing less than 8 millimeters correction, you don't need a graft. But I still graft these because I believe that they increase the stability and the healing of the osteotomy. And then I do the tibial tunnel, modify the anterior screw if needed, and then finally ACL graft passage and fixation. This is a typical case, a 46-year-old male. You can see on the left side that he has some medial arthritis and ACL insufficiency. He needs about a 9-degree correction. This is the stress X-rays, and you can see the opening is symmetrical. These are his MRIs, where you can see that the ACL is missing. He has some damage on the lateral side, but the lateral arthroscopy was all right. So this is what he looks like on the medial side, where we can see that there's a control damage, some meniscal loss. So we did a combined HTO and ACL reconstruction. It's always important to do a superficial MCL release to not to overload the medial compartment after the osteotomy. And then once the intra-articular femoral work is done, then you just have to do your plan your tibial tunnel and try not to hit your implant fixation with the osteotomy. And then the first osteotomy is the vertical one on the tibial tubercle. The second one is the horizontal one. And then thus you have achieved a biplanar osteotomy, and here you have space for your tibial tunnel. And then this is a typical open wedge osteotomy. I won't bore you with the details. Check your alignment, and then fix your graft and your osteotomy. And then the final result would look something like this. And also, we still have increased the slope. Although I did the trapezoidal type osteotomy, you can still see that the unwanted consequences is an increased slope in medial open wedge osteotomies. Our experience is about 42 simultaneous ACL HTOs. Most of them are open wedge biplanars. Almost half of them are primary cases, and half of them are revision cases. We have about 4 to 12 years follow-up. All have undergone single bundle hamstring autografts. No conversion to total knee arthroplasty has occurred. And now we're comparing these patients with isolated HTO patients of the same age and sex to see if their function is similar to isolated HTO. How about the outcomes in the literature? Well, there are two recent publications on this with more than 10 to 12 years follow-up. Return to sports is about 80%, but I don't think it is at the same level. It's the same level sports, which would be about 20 to 30% in my opinion. Progression of the medial OA still may occur in about 33% of the cases. However, the mean IKDC scores are almost 70 in both studies, and no conversion to arthroplasty was seen in both of these studies. This is a meta-analysis, a systematic review of 11 studies in 1,200 knees. The IKDC scores are very good. The side-to-side difference between ACL laxity is about 2 millimeters, which is also good. Return to recreational sports is possible. The OA symptoms regress. The most common complication was deep vein thrombosis in these patients. Other than that, no real important complications were seen. And this is another study for revision ACL surgery plus HTO. The studies are much less, about 7 studies of 77 patients. Most use hamstring tendon grafts. They still report a return to sports up to 9 months, no re-ruptures, and good subjective outcomes. So my take-home messages are, in primary varus knees with acute ACL injury, we don't need any correction of our deformity. We can just do an isolated ACL reconstruction. However, in the chronic or revision ACL deficiency setting, if we have a primary double and varus, we should do a simultaneous HTO plus ACL reconstruction. If we have a triple varus, then we should stage these procedures with osteotomy in the first stage, and the second stage do an ACL reconstruction combined with a lateral reconstruction of the Laprade type. My also messages are the increased slope of the tibial side is an important risk factor for ACL injury and for failure after ACL reconstruction. And tibial slope more than 12 degrees should be addressed during revision surgery with closed wedge anterior osteotomy. However, we do not need to do, the current knowledge says that we do not need to do an osteotomy in acute cases, even if the slope is larger than 12 degrees. Thank you for your attention.
Thank you, Reha, for a wonderful talk. I think that was very enlightening, and I'm sure there will be many questions on this. Anyone has a question for Dr. Reha?
I'm trying to
Yeah, I'll do that.
unshare. Okay, thank you. Thank you.
Yeah. Anybody has a question for Dr. Reha? Atik?
Yeah. So, do you change your rehab by any chance?
Yes, I still do some form of partial weight bearing up to 6 weeks if I combine an osteotomy with an ACL reconstruction. My isolated ACLs, they weight bear fully at 3 weeks. But for the osteotomy patients, I still want them on crutches for about 6 weeks with partial weight bearing. I know this is conservative. Some of my colleagues allow immediate weight bearing. I think that can be done if you have used a locking plate. If you have used the smaller plates, I think it's not safe with the weight bearing.
Yeah, Sanjay?
Dr. Reha, what is the percentage of the concomitant chondral procedures in your ACL with HTO?
Almost all of them need some kind of cartilage surgery. We usually reserve debridements for grade 1 and 2 lesions. For grade 3 and 4, that's a problem. I wouldn't do a mosaicplasty in these slightly older patients because it's too much surgery for them. I would maybe do a microfracture or microfracture plus. That means we have these collagen membranes and bone marrow concentrate. For larger lesions, since they're not going to bear weight anyway for 6 weeks, I would go for a microfracture or microfracture plus. But we know that even if you do nothing, the cartilage regenerates on the medial side after osteotomy. So I think the unloading is more important than the cartilage work, but I still do it, some form of cartilage treatment on almost all of them.
Reha, what is your level of the understanding of the osteotomies for a sportsman, especially the football, elite football? Because I think they have a natural varus.
Yep.
All the athlete, when they want to run for longer duration, they have a natural varus at your proximal tibiofemoral joint, and at that point, what is your level of osteotomy when you try to consider it for ACL deficient knee in an elite football player?
Yeah, if it's an elite football player, I don't think he will be an elite football player after this kind of surgery. We try to aim to not to overcorrect and go to a neutral alignment in these patients. But we know that these guys, they play varus because they play elite football because they have varus knees. And then most of the people, they can return to sports, but I don't think they will have the same level of performance they had before. So it's either elite football or the knee. The sportsman has to decide what to do. Elite football is possible after varus and HDO.
Roshan.
Yes.
Gaurav, you were asking something?
Yes, doctor. Yes, Gaurav.
Roshan.
Yes, unmute yourself, Gaurav.
The amount of times you pass the football in turn is much more than extern, meaning giving it out from the outer side of the leg than on the inner side of the foot. And that is very important in football. Yeah. If you correct into osteotomy and make it valgus, then they cannot do the intern. Okay. That's called a minus pass. As a footballer, I can tell you.
Yeah, just to let our elite gathering know that Dr. Antav is a professional football player in his young days, and still he plays a wonderful football, and that is that is a secret of his fitness.
I think you can be a goalkeeper, Dr. Antav.
Yes. Hello, Reha Tandogan. How are you?
Gaurav, why don't you ask?
Right, Dr. Reha, just. Can you hear me now?
Yes, you can.
Gaurav, yes.
Yeah, just needed to know your technical tips. See, when you are doing an ACLR or an ACL deficient knee, you're doing an HTO, you are intending to decrease the slope. What would be your trick for doing that, and how far on the MCL, as in how far posterior in elevating the MCL would you go to achieve this? So what is the key to success in getting that slope right?
I think the key, MCL, it's easy. I go for full subperiosteal release. That means go all the way under the pes and then release subperiosteally, because we do not want to overload the medial compartment. So that is easy. The second question was, the slope you asking me, it is very difficult, even if you do a correct surgery, to not increase the slope in open wedge tibial osteotomies. Because by the nature of the osteotomy, whatever you do, you have a slight increase in your tibial slope. The tip or the trick is to do an asymmetrical opening. So you do the horizontal leg of your osteotomy parallel to the joint, and then you, with your laminar spreaders, you spread the posterior part more, and you spread the anterior part of the osteotomy less. So you try to open the posterior part of your osteotomy more. Even if you do this, you might still get an increase in your tibial slope, but I think it will be minor.
I have two questions.
Kalpesh?
Yeah,
Kalpesh.
I have two questions. First question is, when patient with a ACL deficient knee, would you advise HTO along with the ACL if the patient has only symptoms of instability but no symptoms of medial compartment, even if he has a varus? Number one. And second thing, on scanogram, what is your cutoff limit beyond which you will advise high tibial osteotomy?
I think both depends on if the medial meniscus is intact and if you have chondral damage on the medial side. So I would even go for 5 or 6 degrees correction if I see on the MRIs bone marrow edema, cartilage damage, and medial meniscal loss in these patients. If they do not have pain, I don't do an osteotomy because you don't change the alignment of the knee if the patient doesn't have symptoms. But if the patient is symptomatic, has medial side pain, medial meniscal loss, and medial cartilage damage, I would even go corrections for 5 degrees. So I think you should be overly aggressive in trying to correct if you have medial cartilage damage.
Thank you.
I think we should go to the next talk now. Roshan?
Yeah, please go ahead with next talk.
Dr. Reha, if you could go on to your next talk, ACL with PCL.
Okay.
Thank you.
I'm just sharing my screen.
Okay. Unmute everyone.
Okay, so this is a very large topic. I tried to combine a few things, and then I hope I'll get the rest of it in the questions part. You have seen my disclosures. They are the same for this presentation. We know that the bundle structure of the PCL is much more defined than the ACL. So we have the anterolateral bundle and the posteromedial bundle, which is more prominent on the femoral side. This is one of the key points, I think, in PCL surgery. The other key point is that the insertion site of the PCL is about 15 millimeters below the joint line. So this is very important to know to make sure that your PCL tunnels or fixation points are in the correct positions. We know that this bundle structure is also more evident in knee motion. You can see as the length of fiber changes more prominent in the PCL during flexion and extension. The meniscofemoral ligaments are also very important for stability. Here you can define these easily by the fibers going to the lateral meniscus, and they add about 20% of the posterior stability of the knee and should be preserved in PCL reconstruction techniques. So combined ACL and PCL injuries are rarely isolated. They are usually a part of multi-ligament injury with, as you all know, with the medial or lateral side involved. We know that they can be due to sports injuries with low energy injuries. In these, the vascular injury rate is very small. They can be in a scenario of motor vehicle accidents, industrial accidents, where the risk of vascular injury is higher. And we also know that we have the ultra low energy injuries in morbid obese patients, usually female, minor trauma. They fall down and they have these ACL or multi-ligament injuries. And these patients are also a high risk for neurovascular injury and complications. So the Schenck classification is the one we use. It's KD2 if it's ACL and PCL only with the collaterals intact, but this is a rare scenario. Most of our patients have, as you well know, one of the collaterals injured. Associated injuries are very high. We all know the peroneal nerve and popliteal artery injuries, but tibial rim fractures and patellar tendon avulsions are also seen and should be sought out for. Emergency management starts with the vascular integrity, maintaining reduction in a brace, if not an anterior external fixation, management of open wounds, and observance for compartment syndrome. Routine arteriography is not indicated in our practice because we can do a clinical monitoring with ankle brachial index. CT angiograms are reliable. Doppler monitoring can also be done. And a angiogram is indicated only if there's a suspicion of a vascular injury. There are some indications for early surgery. These are the open dislocations. patellar tendon rupture, and the knee is unreduced in a fixator. This is such a case that was sent to us in a fixator, but you can see that the PCL is avulsed. The patellar tendon is ruptured completely all the way, and the knee is still unreduced in the fixator. So these patients require emergent surgery. This is the patient, once you open the knee, you can see that everything on the anterior side is torn. This is the medial meniscus torn, and the patellar tendon is torn off the tibia. This is the lateral side, also torn. So for these patients, you cannot wait 3 or 4 weeks for synovial healing. You should do emergent surgery and try to fix everything or almost everything, and then leave the rest for reconstruction. So this is what at the end of surgery, this was just primary repair, no grafts, nothing. The repair of the patellar tendon and the menisci and the capsule. You can achieve some kind of stability for this patient, which we did with primary repair of the PCL, both menisci, and repair of the patellar tendon plus augmentation. So now we have left is the ACL, which we'll do at a later elective stage, but now the knee is out of the fixator and we can start our rehab. Avulsion injuries can occur more in the PCL. A single large fragment like this can be fixed easily with a posterior approach. As we can see here, this is attached to the PCL. So if you fix it in the bed in the tibia, we have a very good result. So if we have in these combined injuries and avulsion, these should be fixed first and then go on to the ACL reconstruction by turning the patient over. And a single screw might be enough for these patients if it's a large fragment and the end result is something like this. If you have a multi-fragment avulsion, you can either go on with multiple screws, as you can see here, or multiple sutures for fixation of the avulsion, and which would look something like this. How about mid-substance injuries? Well, we should start with the exam under anesthesia because the final decision should be made here under exam anesthesia. And then we should also look for the collateral injuries. This is a lateral collateral injury combined with ACL, PCL injury. As you can see, only the medial side is intact. This is a varus stress test. This is a posterior lateral draw test of same patient. You can both see the anterior and posterior drawers. Plus here you can see the posterolateral corner injury where the tibia subluxates the posterior part of the knee, which is a KD3 type injury with ACL, PCL, and the lateral side. The external rotation recurvatum test is the same. This is a patient with ACL, PCL, and posterolateral corner injury. The tibia subluxates posteriorly, the posterior capsular defect. The dial test is also indicated of the popliteal fibular ligament, and you can see that here it's increased, and this is also indication of a posterolateral injury. Or how about the medial side? This is the same patient, ACL, PCL plus medial side. The X-ray and the operative view are seen, and you can see this huge valgus stress test with no endpoint for medial opening. Plain X-rays are not usually like this, but they are usually like this with small avulsion fractures seen from the PCL or the lateral side, which should alert us to a major ligamentous injury. The MRI, of course, looks horrible like this with the knee still subluxated, both ACL and PCL torn, and depending on the force of injury, either the medial or lateral side can also be injured. We should also look for occult fractures on the contralateral compartment because one side is elongated and the other side is compressed. We need to do a good pre-op planning to where to place our incisions. Graft selections can be the contralateral knee if you don't have allografts available. We should plan our implants, and the timing should be 2 to 3 weeks after injury to allow for a synovial seal and do an arthroscopic surgery. However, we have some emergency situations that I've shown you before. In these cases, you cannot wait. So the surgical strategy in these cases can be twofold. One option which I prefer, is to repair or reconstruct all structures in the same setting. This carries a higher risk of arthrofibrosis, and you should have a very skillful team to do this surgery in one setting under one tourniquet if possible. The second option, which is advocated by Stannard and colleagues, is to reconstruct the PCL and repair the collaterals in the first setting and leave the ACL surgery at 6 weeks and do a two-stage surgery. Proponents of this type of surgery think that this produces less arthrofibrosis. However, it has more morbidity. Whatever you do, all reconstructions must be complete before full weight bearing. Otherwise, if you do a weight bearing before you reconstruct everything, these will stretch out once the patient starts weight bearing. So you should have finished everything before weight bearing. How are the surgical principles? Well, first we should reconstruct the center of the knee. That means address the PCL and ACL first. Internally fixate bone avulsions, allograft or contralateral knee for mid-subs injuries, and bring the knee to its anatomical position. And then we should, after we've done that, primary repair of the capsule and menisci should follow, followed by the collaterals and the popliteus, and internal fixation again for bony avulsions, primary repair of the collaterals, especially the medial side, and primary reconstruction of the collaterals if the tissue is of questionable quality, especially this holds true for the lateral side. An arthroscopy is possible usually at 3 weeks. This is an ACL, PCL, posterolateral corner patient. You can see the lateral opening. You can see the popliteus tendon injury, posterolateral capsule. We still have some synovial healing, so we can go on with the arthroscopic reconstruction of the cruciate ligaments and then go on to open surgery for the collaterals. Reconstruction is the cruciates is first. This is a combined ACL PCL injury where you start first with the arthroscopy, do the cruciates first, bring the knee to the anatomical position. We almost always use anatomical single bundle reconstructions because of time constraints and the availability of grafts. We don't want to waste our grafts on double bundles. So it's almost always a single bundle transtibial PCL reconstruction followed by a single bundled anatomical ACL reconstruction. Should we do an inlay? I think not in these cases because it takes too much time. You have to turn the patient if you're doing an open surgery like I do for inlays. So it's transtibial for most of these combined injuries. Should it be a single or double bundle? In acute cases and multi-ligament injury, I prefer to do a single bundle with the AL bundle reconstructed only and leave out the posteromedial bundle here because we know that this is the primary stabilization of the PCL. I think double bundle is more for chronic cases and isolated injuries where you have both the AL bundle and the PM bundle restored. Does it matter? Well, of course, we know that the double bundle PCL reconstruction results in less stable residual laxity, but 1.4 millimeters, I think, is acceptable difference. So I would go against doing a double bundle in these multi-ligament cases. This is an example of a transtibial PCL reconstruction. I'll try to be brief. You can see that the PCL is torn, and as we go under the notch, we can see that there is the medial condyle, there is the insertion site with the shaver. I'm debriding the remnants of the PCL. Then for every patient, we need a posteromedial portal that we can see here, looking from the intercondylar notch to see better and to work as our working portal. And then this is your view from the posteromedial portal. Here you can see the PCL remnants going down back to the tibia here. We can preserve some of these fibers as a remnant preservation. And this area is where your tibial tunnel should go out of the tibia. This is the tibial. We use a tibial guide for, and looking from the posterior medial portal, you can see where we want our graft tibial tunnel to come out. It is advisable to use a PCL type of guide to go as far down in the tibia as possible. And then this is the posterior medial portal view. You can see that I've gone almost, this is about 15 millimeters down from tibial side. This is my guide. And I'm trying to preserve some of the fibers of the PCL on the tibial side, as you can see here. The posterior capsule on your right side. And I'm viewing from the posterior medial portal and working, the drill is coming out from the tibial side. There you go. You can use a protector here if you want when you go out of the tibia, but we are under full visualization here. So no problem with our tibial tunnel. I debride a few of the soft tissue, but leave here on the upper side the PCL fibers intact. And then here is my tibial tunnel, well below the joint line. And this is the remnant of the PCL. And you can see that we are all the way down to the tibia for a good exit on the tibia. For the femoral tunnel, this is the AL bundle that I'm trying to reconstruct. And you can perform your drilling either outside in or inside out. And then finally, the graft passage, starting from the tibia, and then going up to the tibial tunnel. This was an endo-button type device, but you can use screws, whatever you want to fix. This is a device that we created to help with the graft passage. You can see that we are pushing with this device and pulling with this suture to bring up the graft into the joint. And I think it's a very nice device to do that. And then once you have the button inside the joint, then you can pull it into the femoral tunnel and do your graft fixation. And then finally, otherwise you can use a fixation with a screw if you want. If you're not using a button type device, doing it inside out risks damage of the graft, as you can see here, which I don't like. So what I do is I do an outside in fixation in most of these cases. And this is what it should like. And then once you finish this, you can go on and do your ACL reconstruction. And this is what it looks like from the posterior medial portal. This is our graft sitting nicely on the remnants of the PCL. And this is our tibial tunnel on the posterior tibial side. As I said, I prefer to do an outside in femoral fixation because it has less damage on the graft. Then you go on to the peripheral repair. If you have a collateral injury, use suture anchors, avoiding large washer screw combinations, use non-absorbable sutures, and anatomically repair all the capsule or menisci and collateral ligaments. This is a typical case where you have bicruciate injury and MCL tibial side avulsion. The cruciates have been fixed, the knee is in an anatomical position, and then you just have to fix your medial side, the meniscus and the MCL at the end of the surgery, and this is what you get. When everything is finished, your medial side is now closed, you have full range of motion, and then you can see the stability of your knee at the end of surgery. And this is what she looks like at the end. Tibial rim fractures are very important, especially for posterior lateral corner injuries. These should be fixed also. Otherwise, if you don't fix these, you have a residual laxity of everything. How's the rehab? It's slow. It's tailored to the injury pattern and the stability at the end of surgery. I prefer about 10 days immobilization for soft tissue healing, and then immediately start prone flexion. Partial weight bearing for 6 weeks. I use a dynamic brace that pushes the PCL forward for about 2 months and avoid high impact sports for 8 months. What not to do? Well, partial repair and reconstructions are doomed to fail, so we should not do these. Conservative treatment followed by reconstruction is not okay because it is impossible to identify and repair the anatomical structures in chronic cases. And we know that the results of acute surgery, acute meaning in the first 3 weeks, are better than the late reconstructions. Failure to correct all components of the instability is a reason for failure. You can see here that the surgeon in the first surgery decided to do some of the repairs, but not all. So now everything is gone, and now we have to start all over again. We should also beware of posterior fixed dislocations. This was the patient, a chronic case in the pre-op scenario. The first surgery done by the surgeon resulted in some correction, but we still can see that the knee is fixed in the posterior position. I did an extensive surgery, extensive release of everything, and I thought that I could do it. I was stupid. I still could not correct completely the posterior dislocation, even after extensive releases, because you can see here, the posterior structures were all ossified, and even after extensive release, you cannot do a correct reconstruction of the knee. So beware of posterior fixed dislocations. How about the results? They are difficult to standardize because of the variety of injury patterns and techniques, but we know that acute surgery is better than chronic. Primary repair works on the medial side. Reconstruction is more stable on the lateral side. We have worse outcomes in low velocity injuries in obese patients, the ultra low energy injuries. We have also worse outcomes in severe injuries and involvement of the posterolateral corner compared to the medial side. So my take-home messages are: you should correct all components of the instability in the same setting, reconstruct the cruciates, fix bony avulsions, repair collaterals, preserve menisci, and we should also not be afraid of primary reconstruction, even in the acute setting, especially on the lateral side, if you have tissues of poor quality. If you have a spaghetti-like lesion of all the capsule and the collaterals, it is not a good idea to try to repair these. Just go on and do a reconstruction of these tissues. Thank you for your attention.
Thank you, Dr. Reha, for wonderful talk. I think that was a complete summary of all multi-ligament reconstruction along with ACL and PCL. Do you have any question for Dr. Reha?
Yeah, I have one question.
Yeah.
Hello.
Yeah, Ranjit.
Go ahead, Ranjit.
Yeah. Dr. Reha, in case of acute ACL injury with patellar tendon rupture, what is your approach?
Acute ACL plus patellar tendon, right?
Yes.
Okay. Patellar tendon rupture cannot wait. So you have to do an early surgery. You know that we try to wait about 3 or 4 weeks in acute ACL injuries, but this is not the case. So if you leave the patellar tendon unrepaired for 3 weeks, it's a catastrophe. So you should go on with early surgery, and then just you will have more difficulties in rehab, I know, but this is a risk that you have to take.
If you're doing both the patellar tendon and ACL in the same sitting,
yeah.
So what is your post-op rehab protocol? How you rehabilitate them?
I do not do only primary repairs of the patellar tendon. I always augment with the hamstring tendons. So the first issue is the graft. You need the contralateral knee for your graft for the ACL. So you should have both knees prepared, and then you do your ACL, and then you do your patellar tendon repair plus augmentation with hamstrings. At the end of surgery, you check your stable or safe zone of knee flexion. Usually you can go up to 60 degrees without any problem in the patellar tendon. So depending on your situation at the end of surgery, I would start with 0.30 for the first few weeks, go up to 0.60, and then go up to 0.90 at 6 weeks. So it will be a slower rehab, but depending on the stability at the end of surgery. I also augment this, even when I use a graft, with some form of tape that I pass through a tibial tunnel and over the patella for extra security. So primary repair plus tendon augmentation plus some kind of tape or cerclage wire for the patellar tendon repair. I hate cerclage wires because they are almost always going to break. So the patient sees it in X-ray, it's not a good situation. So I use tape instead of cerclage wire.
Okay.
Can I ask a question?
Thank you.
Yeah, sir, please.
One wonderful lecture, Dr. Reha.
Thank you.
Thank you very much. It was nice hearing you the lecture.
Thank you.
Can I ask you two questions? When you had the patellar tendon rupture, was there also MPFL rupture?
No, the patellar was avulsed from the tibial side completely, so no MPFLs.
Okay. Secondly is, what is the choice of grafts in multi-ligament injuries? What do you...
Depending on the country you work and the resources the patient has. I am not afraid to use the contralateral knee. I try to use allografts as much as possible. If that is not an option, I always go for the contralateral knee, get the hamstrings and get the patellar tendon from the other side. Because the injured knee, I don't think is a good idea to harvest additional tissue from an already injured knee.
No, do you ever use a quadriceps tendon?
I might. That is an option. People it's very popular now, the quadriceps tendon. But as I told you, I do not like doing additional incisions or additional surgery that might increase the risk of arthrofibrosis in the injured knee. So even if it was a quadriceps tendon, I would go for the other knee, and I would use it for the PCL because I could use a bone block for the tibial side and then use the tendon part for the femoral side.
Thank you.
Roshan, can I ask? This is Amit.
Yes, please, Amit, go ahead.
Yeah, Amit.
Dr. Rehan, what is your take on angiography after multi-ligament? There are so many protocols coming up and giving different opinion. What is your take on what is your plan? How do you decide either you go for angiography or you don't go for angiography?
I'm sorry, I don't understand. How do I decide on what?
CT angiography.
After dislocation, CT angiography.
CT angiography meaning what?
He's asking for the vascular status.
Vascular status.
I'm sorry. Oh, I'm sorry. Of course. I think if the patient has no pulses, no angiography, you should go directly to surgery. We know where the injury is. We don't want to lose time because we know that amputation is about 60% after 6 hours. So if the patient has no pulse, I don't think you should lose time with angiography. Just go, we know where the injury is, open the posterior medially and repair your vessel. Okay, so if the patient has a pulse, I do not do angiography. I follow, these should be hospitalized always to look for late thrombosis of the popliteal artery due to the thrombosis and intimal damage. But I think a clinical and Doppler follow-up is enough for these patients. Angiography, I almost reserve only for patients where I suspect something. The patient has a weak pulse or not. Other than that, routine angiography, I don't think is good. CT angiography is an option, but it can be used in most centers. But I think a good clinical exam and Doppler and ankle brachial index are enough to follow these patients.
Yeah, Gaurav, you want to ask something?
Thanks. Dr. Reha, that was a very elegant presentation on multi-legs. Just something about PCL. So what percentage of your PCLs do you find an isolated PCL posterior versus what percentage do you find a posterolateral instability combined and end up doing a combined PCL with a posterolateral reconstruction? Your thoughts on that, percentages wise?
I cannot give you exact numbers. We have a case series of over 300 multi-ligament injuries, but I can tell you that isolated PCL injuries are usually low energy sports injuries and most of them are grade 1 and 2 and can be managed conservatively. So most of our cases are that we do surgery are combined PCL and posterolateral corner injuries. I would say about 90% of our cases are PCL combined with something else. About 10% of our cases are isolated grade 3 symptomatic patients that need surgery.
I think we should move on to Dr. Reha's last talk. Atik?
Roshan, just one last question. Can I ask?
Yes, please, sir.
Dr. Reha?
Yes.
You nicely showed that case about flexion deformity following the multi-ligament reconstruction failure. I also had a case like that where there was ACL, PCL, posterior medial corner, plus Pipkin fracture of the hip. We looked after the Pipkin fracture, and then we did the PCL bony avulsion with MCL, repaired that, and then later on, after 6 weeks, we thought we would do the ACL. But then patient had a fixed flexion deformity about 30 to 40 degrees. And we tried to do physiotherapy, stretching, nothing worked out. How will you go about, or what is your guidelines to this?
I think we should differentiate between fixed flexion deformity and fixed posterior dislocation or subluxation. They are completely different. But I would still do what you did. First, start with aggressive physiotherapy and try to see if I can get back my knee extension. We have tried to correct these flexion deformities or posterior subluxations with Ilizarov type fixators. Gradually, our results have been mixed. Some have been good, some have been not so good. We have tried posterior capsular peel-offs from the medial and lateral side with open surgery in these patients. Not so good. I think the only good thing to do is to prevent these. If you have this problem, it is a very difficult problem to correct. And the only two scenarios that you can go to after aggressive physiotherapy is either you do a circular fixator and try to gradually open the knee up, or do an open release of all posterior structures. But both are not very good options.
Okay, Dr. Reha, I think that was a very nice talk, very well put. I think we can go on to your last talk now about failed ACL reconstructions.
Okay.
Thank you.
Okay. So this is my last talk, hopefully.
We are unable to see you.
Dr. Reha, can you share your screen, please?
Okay, just a moment.
So open your presentation in desktop, then press on Zoom icon.
Okay, there you go. Sorry.
Yeah.
It's okay right now?
Yes, right. You can go ahead.
So this, I think, a bit long talk, but I'll try to be brief. The failed ACL reconstruction and management. The disclosures are the same. We know that the 5-year revision rate for ACL surgery is about 2 to 10%, but I think this is a conservative estimate because I know more revisions are being performed, at least in my country, because I have the statistics, than 10%. The risk factors are age, under 20. We know that especially adolescent patients have a higher risk of failure of their ACL surgery. Males, allografts are still a risk factor compared to autografts. Smoking is a risk factor, and interestingly, a family history is also a risk factor for revision. So why do we fail? It's not only recurrent instability, it can also be due to limited range of motion, extensor mechanism problems, pain and post-traumatic arthritis, infection. However, most of them are for recurrent instability. So let's go first forward with the limited range of motion. They are usually due to malposition, but they can also be due to an inadequate rehabilitation program with a prolonged immobilization after surgery, or infrapatellar contracture syndrome that we used to see in the early 90s when you put these patients in a cast. It might be due to a cyclops lesion. Multi-ligament injuries, of course, have a higher risk of limited range of motion and can be due to an infection. The management is to emphasize early full extension in the post-op period to prevent this complication. If we see the patient late, we can still try an aggressive rehabilitation if the tunnel locations are correct. If the tunnel locations are not correct, I don't think we should try to save these knees. We should go in and cut out everything and then try to gain range of motion. If the tunnel locations are okay, manipulation under anesthesia can be performed if there's no progress as 2 months. And I limit myself to arthroscopic lysis of adhesions no longer than 6 months, because later than that, I don't think we'll be able to regain motion. However, if there's a tunnel malposition, then I would advise sacrificing the graft, regaining motion, and do a revision at the second stage. The cyclops lesion, we all know, is something like this. It causes a graft impingement. It can be due to that. It can be a complication of remnant preservation, ACL reconstruction, as speakers before me have told these. They might be due to missed ligament remnants during the index surgery. And the arthroscopic excision in the early period, mixed probably with a notchplasty in patients with a narrow notch, can be successful in restoring extension. Infection is also a risk for limited range of motion. We know that now that vancomycin soaks reduce infection rates considerably, so we should always use these to reduce our infection rates. They can be acute, subacute, or chronic cases, with P. acnes also an important one in the knee as in the shoulder. The CRP rate and the ESR are guidelines. We should know that the CRP normalizes in 3 weeks. So if we have a patient that has a CRP over 100, over normal in more than 3 weeks, and it has a trend to go up and stay up, then we should suspect a subacute infection. So there is no difference between graft types for infection, and the graft is almost always salvageable with arthroscopic debridement and antibiotic therapy in most cases. However, multiple debridements might be needed, usually 2 and up to 3 to salvage the graft. However, if it's a chronic infection, then you have to sacrifice the graft, remove the implant. You almost always see some cysts and in the bone where you have to curate them and place antibiotic beads in these chronic cases. And these are difficult cases to treat. Extensor mechanism problems are also a cause of failure, although rare. We used to have patellar tendon fractures of the patella when we use these grafts. Now I use hamstring grafts almost 90% of the time, so these are rare but may still occur. They can be acute fractures or late stress fractures, which are more important now. And these might also cause failure. So fixation of these fractures are important for the extensor mechanism. We can also have some implant-related problems that we can see in a moment. And we also might see some problems with patellofemoral arthritis, especially in patients with bone patellar tendon bone grafts at 10 to 15 years. These are examples of misplaced or malplaced implants in the patellofemoral joint that might also cause extensor mechanism problems. How about post-traumatic arthritis? Well, it's not rare. This patient is 38 years old, He had his first surgery in about 17 years of age, multiple surgeries, and the result is something like this. And he needs a total knee at the age of 38. Our main problem, as we discussed, is the recurrent instability. It might be due to technical errors. It might be due to failure of biological incorporation. It might be during the trauma during rehab or an acute trauma later on when the patient starts to worsen, or it might be due to mixed laxity of the peripheral structures. However, most of the time, it's a combination of all these factors. So we should not just focus on one problem, but see if we have other problems that are also overlapping our failure mode. In technical errors, we know that the tunnel malposition is the most frequent one. Now we don't see so much misplaced tunnels as we did before. This is a horrible tunnel placement. Now we see more and more tunnels that are placed just at the wrong place, a few millimeters from the original site, and these are harder to revise. We can also see implant failures and graft tensioning errors, especially for double bundled reconstructions. And if we do not pre-tension allografts, these might also undergo stress relaxation and cause residual laxity in time. So this is an example of failure of fixation and malposition of the tunnel. When the patient started moving his knee, the screw just fell out because the tunnel was in the wrong place. We can see a violation of the patellofemoral joint very much in the transtibial techniques in patients operated by some of our junior colleagues. This is more difficult to see, but here you can see something is wrong inside the joint in X-rays. You can see that the button implant has fallen out into the joint and is moving around the joint. The MRI is a bit more helpful, where we can see the broken interference screw inside the joint. So these might also be causes of our failure. We might put the screws too much inside or too much outside, and these still will cause problems of pain and loss of fixation. We can see, I cannot name this because it's a surprise. This is the lateral femoral condyle, and the graft was placed in the center of the weight-bearing zone of the condyle, which is rare to see. And another surprise, the ACL is already intact. So the surgeon did a second ACL in front of the first intact one. So there are some surprises like this, like you can see. Trauma is a cause of failure. This can be early trauma before graft maturation. This can be a micro trauma with repeated forced rehab and early return to sport, or it can be a late trauma after graft maturation when the sportsman returns to sports and there's a second injury. This is usually due to a second major trauma, and the incidence is about 10 to 15%. However, the role of technical errors still exists, I think, because these patients with second injuries usually have some slight problems with their tunnel locations or graft choice. Failure of biological incorporation is another issue. It can be due to a graft impingement of misplaced tunnels. It can be due to infection, overtensioning, allografts, or synthetic ligaments, as you have seen in the 90s and 80s. This is a Dacron graft that I took out for failure. You can see that it has never incorporated and it has broken down, not ruptured, but broken down in the middle of the graft. This is an allograft that I took out. It was a freeze-dried allograft, and you can see in the histological slides that there's a perivascular lymphocytic infiltration. So although we know that there is no graft versus host or host versus graft reaction in allografts, you can see that the immunity plays a factor here, and this still might be a problem in allografts, although we do not see them clinically. Failure to recognize peripheral laxities is another problem. They can be up to 10 to 15% of the cases where the posterolateral laxity was missed, and then the surgeon just did the ACL, and then these failed because of the peripheral structures were not intact. So And you have something like this, which is a catastrophe, I think, which you could not classify. So we start with the history of the primary surgery, the graft type, implants. Was anything done with the menisci and cartilage? And how was the rehab? Was there a re-injury? Was it a minor or major trauma? Was the knee stable until re-injury? This is important because that gives us an idea about the correctness of the first surgery. What are the symptoms? Is it pain? Is it instability? Is it limited range of motion, or a combination of all three? Because we know that these can be different. The physical exam starts with alignment first, because now if we're going to do a revision, we have to know the alignment of the patient. And if it's a varus thrust like this, we should consider correcting the alignment before going on to the revision surgery. Previous incisions are important in patients multiple operated like this. We have to choose which one we're going to use for our surgery. Previously used grafts are important, range of motion, and then the peripheral structures are important. X-rays are very useful for us for tunnel locations. Here you can see that the tunnel locations are horrible, which makes this an easy revision because our tunnels locations are not compromised, and then we can revise these as primary surgery. Weight-bearing X-rays are important for degenerative changes, especially Rosenberg use at 45 degrees of flexion, and also to see the notch morphology where we can see that if there's notch osteophyte or narrowing. We have talked about the alignment, and this is important for revisions. We have to correct the alignment of the patient if we're going to do a revision surgery. CT scans are useful for tunnel widening because we need to do two-stage surgery. I'll come back to this later on. And of course, MRI is needed for the status of the cruciate ligaments, the peripheral ligaments, cartilage damage, meniscal status, and degenerative changes. So we should know that the revision ACL reconstruction is a salvage operation, and it is done for symptomatic instability. We need an active, motivated patient with realistic goals. What are these? A stable knee for activities of daily living, prevention of new trauma, and return to sports at the same level might not always be possible. Graft selections, depending on your country and the availability of autografts and allografts, we can use, as I've told you before, we can use the contralateral knee a lot of the time. Let's start with tunnel management. If this is a patient where the first tunnel was so out of place that it was an easy revision, like a primary ACL reconstruction, because the tunnels that were unviolated, and then a simple revision can be done if the tunnels are way out of the anatomic locations. This was this X-ray before, and you can see a divergent tunnel that we made and fixed with the button device, which was far away from the original tunnel, so no problem with tunnel management in these cases. If the tunnels are near to the anatomic location, a technique that I use is a stacked screw technique. I'm trying to do a double bundle revision here. So you can see that the first metal screw will interfere with our tunnels. I placed a bio screw inside the tunnel of the same size. I drilled my second tunnel just adjacent to it so that I have now a stack screw protecting my tunnel. And then I go on with the reconstruction using the bio screw as a support for my tunnel. So this was the patient's first X-ray. And then here you can see I've put in a bio screw and then done a double bundle reconstruction. How about two-stage surgery? Two-stage is needed for three scenarios. One is loss of motion. If we have a more than 10 degrees extension lag and 30 degrees flexion lag, despite aggressive physiotherapy, I think you should do a two-stage surgery with arthrolysis in the first stage, regain the motion, and then do the second stage. If we have tunnel widening more than 14 millimeters, I would do two-stage surgery, a bone graft first stage, and then do the ACL reconstruction at 6 months. And if there is a malalignment, I would do an osteotomy followed by implant surgery Or, as you've seen in my first presentation, I would do a simultaneous osteotomy and revision ACL reconstruction. So this is a case like this. This was a patient who had been operated with an allograft 3 years ago as a primary surgery. As you can see, the MRI tells something about the tibial tunnel here. However, CT is a better option, and you can see that the patient has a huge tibial defect at the site of the proposed or intended tunnel. So I opted to undergo a 2-stage revision. This is what his surgery looked like. This is the femoral side. And once you've taken out the screw and created out everything, you can see a huge defect, which needs to be grafted. I measure. We love shish kebabs in Turkey, you know, so we created a shish kebab, put this from the medial portal, and then put it inside and impacted on the femoral tunnel. And then on the tibial side, we did the same. See, look at the huge Acl crest graft. Make sure that you go all the way up to the joint line, because this is where your tunnel exit will be. I try to leave the implants in place if they're not interfering. However, if they're interfering, I take them out. This is his x-rays, early post-op. This is at 4 months. We can see that they have consolidated the grafts. And then this is at CT at 6 months, where we can see that the grafts are very nice. And then this is the second revision scenario, where you can drill your tunnels as if it was a primary surgery, and then go on and do your revision. And this is what he looks like in the post-op period and at 3 months post-revision. We should also graft these patients. This is a multiply ACL, PCL operated patients. He underwent 4 different ACL and PCL reconstruction surgeries, each with tunnels like this, and all of them failed. So now if you have a situation like this, you have to undergo 2-stage surgery, graft everything, wait, regain motion, and then do your revision at the 2nd stage, which I did something like this. How about graft fixation? If the first tunnels were far away from the anatomical site, standard fixation is adequate. However, you might need extracortical fixation to support, because of the osteoporosis of these patients. Some of them had not been weight-bearing for some time, and you might need some additional fixation if the purchase of your first implants are not very large. Also, if you have very large tunnel cavities, you might need to use backup fixation in these patients. Therefore, you should always have the necessary implants and instrumentation in these revision scenarios. How about the results? Of course, they are not as good as primary ACL surgery, with lower lysome scores, lower IKDC scores, higher residual pivot shift in these patients, and higher rates of radiographic osteoarthritis. We can say that we can have important gains in stability, but the scores, outcome scores, are inferior due to meniscal and chondral pathology. How about return to sport, where it is lower than primary ACL reconstruction? These are very good studies, systematic reviews done in different times. Return to sport at the same level is about 40 to 50%, which is, I think, a very optimistic view, because most of the patients return to some level of sport, but not at the same level before injury. I thank you all, and just would like to remind you about our courses in Istanbul, that we do cadaver courses with the ECA on ACL surgery. Thank you.
Thank you, Dr. Reha.
That was a very elaborative talk, Dr. Reha. Wonderful talk. I enjoyed it, every bit of it.
Excellent talk.
Very informative, very
informative. Probably one of the best talk I have ever heard on the revision ACL.
Especially revision ACL was phenomenal. You have covered everything. We can't ask you any questions now. All our doubts you have cleared.
So
the graft you take is from Dr. Riah, is from the iliac crest?
Yes.
I see. And the wire, the K wire that you use is what diameter?
It is the tibial guide wire that we use in the set. So we just put it in the graft. It's about, I think, 3.5.
That's a very good idea to put the graft with the front.
Yeah.
We do it with the oat set, you know, 8 millimeter or 10 millimeter diameter. But sometimes it's very difficult to get that size, you know, oats reamer, so that which can fit in our tunnels. But I think this sheikh kebab technique is fantastic. I learned it today.
Do you ever use composite grafts to fill up the defects anytime?
Composite being what?
Calcium phosphate.
High calcium phosphate.
No. I always use autografts for these patients.
I think any other person has a question? Any other consultants has a question for Dr. Reha on all his talks, osteotomy, the revision?
Roshan, can I ask a question?
Yes, Jayaprasad, yes.
Yeah, Reha, Dr. Reha, if the patient is having a femoral tunnel blowout, so how to bone graft these patients? How to bone graft?
Femoral tunnel blowout, meaning you have a posterior cortical blowout? Yeah, okay.
Posterior cortical blowout.
Okay, so this would usually happen if you are doing a transtibial technique. Because otherwise, if you approach from the anteromedial portal, posterior tunnel blowout is very, very, very difficult to do. So what I would do would to switch to an anteromedial portal technique using an accessory anteromedial portal and drill a tunnel, a divergent tunnel without grafting, because the exit point is now more lateral on the femoral condyle. So I would never need to do grafting of these patients. Or you can go to an outside-in technique if you do not want to do an intermedial portal technique. Just reverse, start from the lateral condyle. You can end up in the same place, but your exit now will be on the lateral side. So you still don't need to graft these patients. I would suggest using an additional cortical fixation on the lateral side. So don't graft, drill a divergent tunnel and use extracortical fixation.
Anybody?
Dr. Reha?
Yes, Dr. Anta.
When you are doing osteotomy, can you give your tips and tricks where exactly you put the grafts, more anterior, in the middle, or posterior? If you put posterior, then it's like you have reduced the slope, you know. How you adjust the graft when you put it?
Yes, as we talked before, I take two grafts, the bone grafts from the iliac crest. I use the thicker one for the posterior part, and I use the thinner one for the anterior part, not to increase the slope.
I see.
Anyone has any questions?
I think if there is no question, we will like to end the meeting. Dr. Reha, it was a wonderful having you, and listening to all your talks. They're really enlightening us, and a fantastic way of presenting, especially your last talk on revision was fabulous. I think all the Indian fraternity on the group must have enjoyed this, as well as we have it on YouTube for our future recordings and future viewing. Thank you, Dr. Amit, for starting, and you have been a very good friend of us from neighboring country, Nepal, but you have a phenomenal work in your country, and we all appreciate your efforts.
He's the master class there.
Yeah, he's a master class in Nepal. And Vivek, my very good friend, has left. I think he's joined some other meeting. So thanks, Vivek. And thank you everyone for wonderful. Reha, thanks again for joining us. Probably we'll see you shortly in Mumbai or India somewhere.
Yes. Thank you, Dr. Reha. Thank you,
Dr. Reha.
Thank you.
So enlightening, so much from the heart, so much from the experience.
Yeah. Thanks.
Bye. Thanks, everybody.
I will end
live stream.